hope everyone's having a good day. Buenos dias. Espero que todos estén teniendo un buen día. Please forgive my pronunciation. I'm still a learner. I hope everybody's having a good day, though. My name is Allison Lovell. I'm the Business Operations Administrator over here at the Arizona Advisory Council on Indian Healthcare. And I've worked with different aspects of, healthcare claims, billing, and operationalizing, apologize, haven't had my coffee yet, different aspects of reimbursement opportunities for everything from hospital systems to working with providers. I was over in MCO programs previously, hospital systems, and then I was the policy and education manager specifically for provider training over at Access for about 4.5 years. So I've had a fair amount of experience in these different areas, and I absolutely love and adore CHRs and CHWs. I'm a little bit biased because I used to be one over in inner city Cleveland where I grew up. So let's get started on the presentation. So we did want to say a special thank you to the Arizona Department of Health Services, the Arizona Community Health Workers Association, ASCHO, our team here, and for making the presentation possible. Today, in terms of questions, if you have questions, just toss them into the chat. I'll periodically stop to go through those. And I believe we'll be sending this presentation out afterwards, correct, for the hosts? If not, I'll make sure it gets posted to our website. We're still building that out. So our learning objectives. One of the main things that we do is we like to make sure that providers, in particular new providers or new programs, understand their different options for billing. I feel like in Arizona, we really do a great job of working through community-based organizations and through different state departments and at the tribal level as well in working on those different areas and opportunities. So we're going to cover today, because it's a very wide topic, so we can't cover everything, of course. But we'll cover the basics for Medicare and Medicaid, because both of these are two new aspects of billing for community health worker organizations. So we'll talk about, what services can be billed, what codes, how many hours you can do, prior auths, if there's going to be any policy conditions. So like, is there a health condition or barrier that a member or patient has to be experiencing in order to bill, what providers are eligible to bill, what documentation and records you need to keep. So just keep in mind, this guidance was meant to assist with billing, not with the CHW or CHR certification process. That's a whole separate topic. So let's just do a quick overview of the health insurance landscape. As I mentioned, today we're going to talk about Medicaid and Medicare. We're going to talk about Medicare first, actually. But there are other different types of health insurance. So CHIPS or Kids Care is also a type of Medicaid for children. The IHS system also is a type of, it's not necessarily health insurance, but it is a system where members of a federally recognized tribe can receive health services. There's also the Veterans Health Administration, and these are type of public health insurances. There's also private health insurances, and some of these are actually starting to look into potentially reimbursing CHW and CHR services. So as that situation develops, we'll provide more and more information depending upon where they all land. But some examples of private health insurance would be things like employer-sponsored. So that's when you're talking about things, like Blue Cross Blue Shield, United Healthcare, Aetna, Kaiser Permanente, things like that. You also have, TRICARE. There are different marketplace insurances that you can purchase. So there's overlap between the types of insurance, between employer group and marketplace, because you can usually buy a lot of those employer-sponsored ones through the marketplace just at different premiums. COBRA insurance, of course, which is like a bridge after somebody has separated from employment. And there's just many, many more types of private health insurance options. So one of the big things we want to emphasize, and this is important because dates matter, we want to emphasize that in Arizona, you could have started billing for CHW services last year, actually, as of April 1st, 2023. Now, you would have to be billing in conjunction with a actually already registered access provider, and we'll go over a list of what those providers are. But you could enter into a business agreement with those different providers and have them do the billing on behalf of your organization. So in those types of cases, you would do something like have your CEO or COO or your CFO work with that particular provider's finance office, and you would form a legal contract stating, hey, you provide us, If you have referrals for this, you're going to be doing our billing for us, and we will see patients for you as a part of your practice, but we'll still be a separate entity, but we'll see patients for you. And we will send you our visit notes, and you'll send us, your referrals that you want us to go out and see people on, and then you'll do the billing, and you'll maybe keep, 30% of the reimbursement that comes from Medicaid, and we'll keep 70% of the reimbursement that comes from Medicaid. So you work out a deal with whoever that provider is that's going to be doing the billing for you. It's a standard, billing arrangement. So that being said, that's going to look different for every single CHR organization. It's going to look different for every single one of them. There's going to be different rate negotiations, and we can't really provide a whole lot of advice on that because it's really just up to each CHW organization if they want to enter into a billing relationship with a provider type that's already registered with Access, and that would mean they don't have to register separately with Access then. So if you go that route, you would basically do that on your own and just determine what those percentages are in conjunction of who you were going to form that partnership with. You can also have the option in Arizona now as of April 1st, 2024, to register independently of Access as a CHW organization provider type. And if you do that, then you can do your own billing for services. So you don't have to worry about entering into a contract or an arrangement with a provider to do the billing for you. Now for Medicare, Medicare also has started reimbursing services that are provided by CHWs. And that's brand new too, actually. It's, as of January 1st of this year. So it's very brand new. There's some overlap between the services that are billable between Medicaid and Medicare, but the codes are different. So some of the services, can be similar. So we're going to talk about that. But for Medicare, it's specifically for community health integration services and for principal illness navigation services. So it's always important to talk about costs just very briefly. For Medicaid patients, these are going to be covered under the Medicaid enrollment. So that's going to be something that is completely covered for the patient. For Medicare, if this falls under the part of Medicare that's called the Medicare Part B plan, and amounts that a patient owes will vary. They're going to vary, unfortunately. It's not quite as inclusive as Medicaid is, unfortunately. So say somebody has Medicare and they're not a dual eligible member. And dual eligibility just means you have a patient or somebody that you're going to see as a CHW that is enrolled in Medicare and Medicaid. That's called dual eligibility. So someone who is dually eligible, they can do this thing called cost sharing, where Medicare will bill for some of the services, and then they can bill Medicaid for the rest of the services. We're not quite there yet with CHW services because the codes are different, but what can happen is if you have a dual eligible person and you provide a CHI or a PIN service for a Medicare patient, and you bill Medicare and they pay what they're going to pay, the coinsurance or the copay deductible sometimes can be billed to Medicaid then, and Medicaid will pay that. And that is what dual eligibility can look like. And it varies based off their eligibility. It can get very complex. But just know that that is an option sometimes for dual eligible members. I want that to be your takeaway. Someone who's enrolled in Medicare and Medicaid, sometimes Medicaid is going to be able to pay their copays, coinsurance, or deductibles. So these are things your billing department should be discussing with patients when they are going to get CHW services, if they're going to be receiving them under the Medicare umbrella. Say somebody isn't dual eligible. At that point, they may owe up to 20% of the Medicare approved amount of the rate after they meet their Part B deductible. So Medicare, Part B, that often works like just regular health insurance, like group-sponsored or employee insurance, or something that you'd get on the marketplace. So say, it's January 15th and you have a new patient with Medicare and they're going to start getting services. And say they have a $1,000 deductible through Medicare. I'm going a little bit high probably, but let's just say it's $1,000. So they haven't met that yet. So the CHW services that they're receiving through your organizations, they're going to owe 100% of those costs till they meet the deductible if they just have Medicare. So just be aware that there are all these different insurance caveats that can cause patients that you see some anxiety when it comes to the amount of money they're spending for services. A little bit later in the year, once Medicare patients have met their deductibles, they owe significantly less than for services. It'll be, like 20% usually of what the Medicare approved amount will be. So just keep that in mind. It really can wildly vary when it comes to Medicare patients. So for sustainability, the reason we talk about this is because the support of sustainable program, you really need to bill for services rendered. And right now, a lot of CHW programs are really launching their billing services, and it's new. It's new. They've been providing the services. They know what they're doing. They do an amazing job. CHWs I think are honestly singularly responsible for turning the pandemic around during the public health emergency here in Arizona. They are heroes in my eyes. I think they're amazing here. And one of the things that is starting to occur is a lot of those grants that were funding programs are starting to go away. So that brings the question of how are we going to fund these programs? And we get that question a lot. Hey, how do we make our programs sustainable when we're grant funded? Well, you start to transition away from using grant funds and start to build a robust referral and billing system. That way, when the grant is, ending, you already are going to be able to make that seamless transition and just immediately start billing. So having all of those things in place before grant funds run out is absolutely vital. So we're going to address some of those, basic items. Let's talk about Medicare. And does anybody have any questions on that piece yet? I don't see anything in the chat, so I'll keep going. So Medicare, as I mentioned, is now available for billing CHW services as of January 1st. So what is going to be paid by Medicare? There's something called a social determinants of health assessment that is done by the provider. So that wouldn't be done by the CHW organization. That's going to be done by the referring provider. And that can be done every 6 months. In fact, it needs to be done every 6 months if they are receiving CHW services. So if you have a patient who is receiving those and it's been 6 months since the last referral or last assessment, their provider needs to do another one. So keep that in mind. Now, if the assessment that they get done indicates that they would benefit from CHW services, it has to fall under one of two umbrellas, something called Community Health Integration Services, or CHI services, or Principal Illness Navigation Services, or PIN services. And these services can be provided by certified or trained auxiliary personnel, and that includes community health workers and community health representatives. So the caveat here is that if you are going to bill for services to Medicare that your program does, the individuals have to be voluntarily certified. Now, there is no federal requirement that individuals have to be, registered nationally to provide services. But in the language, in the all that legalese that comes out regarding allowing CHW services to be billable for Medicare patients, within that legalese is a statement that says if a state has a certification program, in order to bill, they must be certified through that program, or otherwise they just have to meet, minimum standards that are, normal and practical for CHWs to be trained in. But because Arizona is a state that has a CHW voluntary certification program in the state of Arizona, CHWs have to be certified if you're going to bill for those services. So that's a commonality between Medicare and Medicaid. It makes it actually easy for CHW organizations to set up that aspect of their, their operations for their sustainability. You can just create, one file to track all of your CHWs that work for you, to make sure that they all are current on their, continuing education, to make sure that they're all current on their voluntary certification. And when their voluntary certification is about to expire, you want to make sure that you're notifying your team members of that and saying, hey, your voluntary certification is about to expire. This needs to be renewed because we can't be sending you out to see patients if it's expired because we can't bill for that. So that is one of the first, kind of building blocks. You have to make sure everybody's voluntarily certified to bill for Medicare and Medicaid. Now, the other thing is, it has to always, any service must be performed under the direction of a Medicare billing practitioner if you're billing Medicare. So this means that not any provider can, provide the referral for this. The provider has to be registered with Medicare and able to bill Medicare. So that is something that you would need to make sure that whoever's sending you that referral that they bill Medicare. And to be honest, most providers are able to bill Medicare for services. There's not a whole lot that can't, but I would be remiss if I did not point that out. They have to be a Medicare billing practitioner. And that just simply means the provider can independently bill for services. So these are going to be individuals that are like a physician, like an MD or a DO, or maybe even a physician assistant or a nurse practitioner. When you think about an independent provider, that's somebody who's going to, register independently with their own national provider identifier number. It's somebody who is going to be able to write prescriptions for things. So that's always kind of a way I like to cheat and tell people, if you have doubt about whether somebody can do a referral, ask yourself, are they able to write a prescription? Or are they able to write a prescription under, the supervision of somebody else? And if the answer is yes, usually they are able to do that referral. So the billable codes to Medicare, as I mentioned, there's 3 groups of this. There's the social determinant of health assessment, and that is done by whoever is doing the initial assessment, so that independent Medicare provider. And then there's going to be the community health integration or CHI service codes, and then there's going to be the principal illness navigation or PIN codes. So we'll talk about this one very briefly. This is what gets everything kicked off. A provider has to do a SDOH assessment, and that's to assess those risk factors that influence diagnosis or treatment of medical conditions. And if anybody that you're working with has any anxiety about this, it's really easy. They can do it any type of wellness visit or E&M visit. And an E&M visit is an evaluation and management visit. Super easy. It goes by, pretty quickly. Think of that as if you go into the physician's office and have a sinus infection, or you need, your yearly checkup. And you'll go in and they'll just do, 5 to 20 minutes screening tool. Usually the patient fills it out, and it doesn't take a long time. And then that provider can bill with the G0136 code for that assessment. Now, after that, you have to make sure that if there's a screening tool used, just make sure that the providers you're working with, the ones that are going to be doing these assessments and sending you referrals, they know that it has to be an approved assessment screening tool. So here are some examples of screening tools that are approved. As you can see, we've provided 3 examples, and these are, they're all very good screening tools. They vary in length, but they're usually fairly short. So this first one from the National Association of Community Health Centers, there's, 15 core questions and 5 supplement questions that may or may not apply to the individual. There's also on the CMS one, it's only 10 questions. And then there is another one that is 11 questions, a short form one, but the long one has significantly more questions. So say, there's an individual who has a lot going on. They have a lot of challenges in their lives, and they have a lot of social determinants of health to contend with, which we see in rural areas. You're going to want to make sure they try to take a longer version of one of these, just so that you have a full, full picture of how to help them best. So let's dive right in. If that practitioner who does that assessment says, hey, they really do need some community health workers to go out and see them, some of these services are going to fall under community health integration or the CHI service codes. And these are the codes. When you bill, you would use one of these codes. So the first one, G0019, that just means that a CHW is going out to visit the member, and it's for the first hour. And the amount can vary about how much you receive back, but you need to calculate these items when you're planning the sustainability program. You want to get a good idea of how much you're going to be reimbursed for the services provided to members or to the patients that you see. And that will allow you to get a general billing estimate of how much revenue you're going to be bringing into your service. I think a lot of the times we really concentrate on the patient care aspect, which is the most important part of the work that we do. But we cannot continue patient care if we don't have funding to continue those programs. So we do have to talk about the money aspect. And the money aspect, these are some general, pretty decent numbers that you could use to make some cost estimates. So say you have, 50 different, patients that you see each week, and you see them for maybe 3 hours each week, you can do a pretty decent calculation from this based off that. And these other codes, the G0022, that's just for every additional 30 minutes per calendar month. So say you had 3 hours of service for a member in the entire month, you would bill 1 unit of G0019, and then you would bill 4 units of G0022. So the G0019 covers the first 60 minutes, and then the G0022, you bill 4 units of that because each unit is 30 minutes, and that would bring you up to 3 hours. So 1 hour for the first code and then 2 additional hours for the second code. Now, the G0511 code, that one is used by FQHCs and RHCs. So, rural health centers, federally qualified health centers. And that's a general care management code. It's used for other things as well, but this is actually, this has been earmarked to be used for both CHI and PIN services. Now, what are these services? These are to address unmet social determinants of health needs that significantly limit the ability to diagnose and treat the patient's medical problems. So that's really just a fancy way of saying if there is an individual out there in the community that's struggling because they have social determinants of health affecting their day-to-day lives. Maybe they're living in extreme poverty. Maybe they have food insecurity. Maybe they're a diabetic, they're on insulin, and they don't have electricity or refrigeration. Maybe they're an individual who, has suffered some type of horrible trauma and they are, they're dealing with the aftermath. Maybe they're in an abuse situation. Regardless of what it is, there's going to be some type of social determinant of health that is limiting their ability to, handle their medical problems. And their medical problems could be physical health or behavioral health. So a lot of times we know there's obviously that mind-body link. If somebody's going through extreme poverty, or if they have food insecurity or housing insecurity, they're going to have a lot more trouble when it comes to mental health because they're going to be anxious, they're going to be depressed. Every single day it's going to be a fight or flight situation for them. So that alone would trigger the need for, CHI services for that member. Another thing that you could, consider for this is when you're billing for services, always remember you have to be able to document that there was that initial visit where that assessment was done. And you may go out to the patient's house and see them, but you need to make sure that when you are there, you're following the social determinants of health that were identified on that assessment, and you're addressing those areas for the patient. And you need to document all of that and how you addressed it while you were there, and also work with that provider to make sure that there's a treatment plan. You will be an integral part of establishing that because when you go out, you may be told, hey, this person has extreme poverty and food insecurity, and they have diabetes. Their electricity is about to be turned off. They're having a lot of issues with that, and they're extremely depressed. Maybe they have suicidal ideation. So you're going out to provide them resources, resource navigation, all that good stuff to help them. But say you get there and you find out that there's a language barrier, and that's also contributing to them not understanding how to follow their plan of care for all the different health conditions they have, because there's a language barrier that their doctor's office wasn't aware of. That happens a lot. So then you would make sure to get that added to the treatment plan. Now, keep in mind the services must be directly related to that social determinant of health that was documented by that provider who did that social determinant of assessment. And the assessment I'm talking about, again, is the one that is here. So one of these 3 assessments. It has to be documented there. That doesn't mean you can't add additional things as a part of the treatment plan that you identified, but the provider needs to be aware and add it to the treatment plan formally. So CHI services can be things like a person-centered assessment. You can facilitate goal setting of them. You can provide tailored support to the patient according to their treatment plan. You can coordinate patient services amongst all different provider types. If anybody here who's ever tried to schedule a surgery knows what a pain in the butt it is. You have to, schedule it with your surgeon. Then you have to make sure that, your surgeon's a network. But then you have to make sure that the hospital you're going to have it at is also a network, because you can have a situation where you have a patient who the physician's a network or the surgeon's a network, but the hospital, the facility the surgery's at is out of network. So that can land them with a $10,000 bill. So a lot of patients have anxiety about this thing. They'll actually put off health care that they need or procedures that they need because they don't know how to navigate the system. Anesthesia costs are another issue that a lot of CHWs can really help with, that navigation of, making sure that if somebody's having a procedure, that the anesthesiologist assigned to that, surgery, making sure they're in network for that member's health plan. Because a lot of times anesthesiologists are they're very independent in how they practice. So you could have an in-network facility, an in-network surgeon, and an out-of-network anesthesiologist, and the patient could get hit with a really big bill for that. So coordinating services between different provider types and to facilitate access to services is a very important part of CHI services. Additionally, accessing social services. When we talk about those social determinants of health, somebody's food insecurity, you can help them access, social services. You can help them to get food stamps. You can help them to apply for WIC. You can, if they have children, you can help them with all kinds of things like that, and that's all part of a CHI service. And you can also do care transitions. So someone goes to the emergency department. Say they have chest pain and they wind up in there, and they're discharged home, or say they're in an accident, knock on wood, hopefully nobody is, but, everyday people wind up in the hospital from accidents, and they have to do step-down units or go to a skilled nursing facility or a rehab facility for, rehabbing their injury that they have. And you can help to coordinate the transitions between those different facilities and then back home. You can support patients in medical decision-making. Translators are so key for that. And you can do provider, you can do health education recommended by the provider to help identify areas that the patient needs some additional assistance on. Healthcare is overwhelming. It's impossible to know every aspect, even if you are a healthcare provider yourself. So you guys can provide those essential health education services, those resource connection services, the social service, or system navigation between different types of healthcare providers, or understanding health insurance. You can act as translators. You can help them with those self-advocacy skills to self-promote for better treatment. Additionally, we mentioned the healthcare system and navigation of it, but social and emotional support services are important too. A lot of people don't necessarily have family that can help them, and CHWs may be the most social contact that they have, and that's so incredibly important. If there's behavioral changes that you've noticed, you can, help make sure that their providers are aware of that, because maybe their diagnosis is changing, maybe they're getting worse, maybe they're improving. And you can also draw on lived experience to support patients to meet treatment goals, because there is a disconnect between Western medicine and traditional medicine, and CHWs play a critical role in navigating that. Now let's talk about PIN services. These are the 3 codes for PIN services. You'll recognize G0511 as the same one you use for billing for the CHI services, the Community Health Integration Services. It's the same for both, for FQHCs and RHCs, but the codes are different for other PIN services. So again, we have a code for the first 60 minutes, the G0023, and we have a code for the additional 30 minutes each month, so G0024. What's different about PIN services is there are specific codes for behavioral health. So say you have somebody that you're seeing because they have a lot of, health conditions. Maybe they have cancer, maybe they have diabetes and cancer, and maybe they also have liver failure. They just have a lot going on. Well, those are health, physical health conditions. So you would use the G0023 and G0024 codes for that. But say they have a behavioral health condition and their social determinants of health are making that worse, and it's hard for them to manage that. Well, then you would go to these codes, G0140 and G0146. So just know the difference between the CHI and PIN codes is the PIN have separate codes for behavioral health. And now, prior to PIN services, just remember, you need that social determinant of health assessment done, same as before CHI services start. You need to make sure there's medical necessity for them, and there has to be a treatment plan. Now, for PIN services, it's a little bit different because you have additional requirements. So again, it's called Principal Illness Navigation for a reason. And in order to qualify for PIN as opposed to CHI services, you would have to have somebody who has a serious high-risk disease that's expected to last 3 months or more. So it's something that's going to last a while, like cancer, like diabetes type 1 or type 2. You would have to have a disease-specific care plan for that patient that may require frequent adjustment in medication or treatment, or substantial assistance from a caregiver. So an example of that would be, say you have somebody who has suicidal ideation. Maybe they had to, use crisis services, and then their provider did that, social determinant of health assessment, and they have serious depression. So that requires very careful medication adjustment a lot of the times, especially when it's first diagnosed. So that would qualify. And then you would also need to make sure that the disease places the individual at significant risk of hospitalization, nursing home placement, or acute expiration, or functional decline or death. So basically, it's something serious. So some examples of conditions that qualify are things like a serious mental illness, substance use disorders, that's a big one nationwide, uncontrolled diabetes type 1 or 2, HIV, dementia, congestive heart failure, cancer, or COPD. So these services can be things like assessments that are person-centered, and they identify or refer the patient to appropriate support services. So if you have somebody with dementia, maybe they need a specific type of memory care placement. It also includes, all of that care coordination that you would do under CHI. So that can also fall under this. This has more health education, though. PIN services are much more heavy on the health education aspect because they have a specific high-risk illness that places them at a higher risk of functional decline or death or hospital placement or being placed in a skilled nursing facility. So health education is really key, and that's where CHWs really come in here. Additionally, an overlap between PIN and CHI services are the healthcare access and system navigation. That falls under both. Same with facilitating behavioral changes as necessary for meeting diagnosis and treatment goals. So one of the things that can actually fall under this as well that's very important is if you notice that your patient has behaviors that are detrimental to their health. When I was a CHW, I had went into one of my favorite clients' home, and I found that they had started smoking. The problem here is they were a COPD patient, and they were on oxygen. So they were literally smoking while on oxygen. So you can see why a behavioral change needed to be made immediately for their own safety. So that's an example of something CHWs can do. Another example is dietary changes. That's huge. You get congestive heart failure, your salt intake is going to go down. So CHWs can really help on that, and it helps health education and facilitating those behavioral changes go hand in hand. The providing social and emotional support, that's an overlap between PIN and CHI services. And then just leveraging knowledge of the condition and lived experiences. Now, who can bill? Medicare billing providers and practices only. So that's kind of the downside here, everyone. With Medicaid, CHW organizations can register access and bill themselves. But remember how I mentioned earlier that you can form contracts with providers and they could bill and then they'll reimburse you whatever percentage you work out? You have to do that with Medicare because there is no setup right now for CH provider types to bill Medicare independently. So you have to enter into some type of agreement with a Medicare billing provider or practice. And that setup's very similar to how phase 1 of Medicaid billing rollout worked, which is why we talked about that a little bit earlier. You might have CH provider types that are registered with the state Medicaid agency, but they still can't bill Medicare directly. They have to enter into those contracts with the Medicare billing practitioner. So what does that look like? It could be entering into a contract with an IHS facility, or with, a 638 or an urban Indian health group if you are serving tribal members. It could be entering into a contract with the local psychiatrist if you're getting behavioral health referrals. It could be entering into a contract with the local, MD or it could be just entering into an agreement with an FQHC or a clinic. So it's going to vary based off who you want to enter into those agreements with. So as we mentioned, when it comes to these contracts, you enter into the contract with that Medicare billing practitioner, like a doctor's office or, ITUs, and they conduct that initial E&M visit or wellness visit. They do a social determinant of health assessment for you. And then if there are any that are identified, they document the need for a community health integration or a principal illness navigation service, and they make a treatment plan. They send that referral over to you guys as the CHWs, and you see the patient. Then you provide those notes back to the provider. They bill, they receive the reimbursement, and then they pay you guys. So it's pretty much just like having, a standard contractor agreement. Please note that for dual eligible patients who have both Medicare and Medicaid, referral is required for Medicaid services, and there's different codes. Additionally, the CHR, as we mentioned, they're going to perform those services. You got to make sure you're keeping visit notes and documentation. This is big. One of the things that differs between Medicare and Medicaid is the length of time that you have to keep documentation on file. Medicare, there are nuances, but I always tell people Medicare, 10 years, Medicaid, 6 years. So if you're going to maximize your reimbursement, here's the takeaway. Make it easy on your staff. Just keep it for 10 years. Keep it for 10 years, and then you don't have to train staff to take a look and possibly make a mistake by going, oh, I thought they were on Medicaid, but turns out they were on Medicare, so we threw away the files. Like, you don't want to do that. Standardize it. Medicare requires 10 years and Medicaid 6. So just keep that in mind for any of your documentation. You got to keep it. Visit notes and documentation, those have to be available to the Medicare billing practitioner's office so that they can bill and provide any necessary information to CMS when they are being reimbursed. So who can bill for these services? So some examples of organizations that can provide CHR services and that a Medicare billing practitioner can contract with include tribal CHR programs, community-based organizations, community health organizations, community action agencies, housing agencies, area agencies on aging, centers for independent living, and aging and disability resource centers. So these are all types of agencies that can have CHRs. It's not, this is not a limiting list, by the way. These are just some examples. But organizations like this can enter into contracts with a Medicare billing practitioner. And as I mentioned before, the legalese, there's no license that's nationally required, but the rule states that all CHWs providing CHI services need to be certified or trained to perform all included service elements and authorized to perform them under applicable state laws and regulations. So translation for that from legalese to just normal English is if your state has a voluntary certification program or any mandatory certification program, they have to be certified for you to bill. So for us, they have to be voluntarily certified. So let's see, if Medicare members are empaneled with an AME that is reimbursed for diabetic education services, are CHW, CHR not able to bill for those services? Correct, Amanda. And that falls into Medicaid. So there are, I forgot the actual name of the law, but it's considered double dipping. So if you have a Medicaid member, well, for Medicaid, for sure, you can't bill. For Medicare, they actually have not provided, sure guidance on that. They actually have not provided anything in writing on that at this time, but that would still fall under the same type of double dipping regulations. So, for diabetic counseling and education, theoretically, you shouldn't be if they are, receiving that through the AME. What you could do is look for social determinants of health, though, that affect their ability to manage their diabetes. So you're not really doing diabetic education there. You could do education for social determinants of health that adversely affect their diabetes. So it's kind of a gray area. You can definitely provide community health integration and principal illness navigation services to patients who have diabetes who are enrolled in an AME, as long as you are primarily addressing those social determinants of health that are adversely affecting their condition, as opposed to the diabetic education component. So you basically have to be offering something that they're not receiving through the AME's diabetic education. Does that make sense? So basically just, okay, perfect. Yeah, and that's a great question. So just make sure on visit notes and the treatment plan, it's very well delineated what you are doing and how it is different from what the AME is doing. And also for everybody, if you're not familiar with an AME, that's called an American Indian Medical Home, and we just call it AME for short because it's like a cute name and it's, makes it easier to say because we love acronyms in Arizona. And some AMEs do provide diabetic education services while others do not. So just because someone's enrolled in an AME doesn't mean, that you automatically can't provide services. But it does mean that you have to check to see if they have diabetic education being provided. And if so, you can't really overlap with that, but you can provide, the PIN and CHI services to address the things surrounding it. It's a lot easier to provide Medicare services to somebody who's enrolled in an AME and that has diabetic education services than it is to do Medicaid services for someone with an AME. You really can't for someone who has diabetes, is enrolled in an AME with diabetic education, and you want to bill for Medicaid to address that, you can't. Like, that's a hard stop because the only services eligible for Medicaid, and we'll talk about this in actually just a second, but those particular codes overlap, unfortunately. So it's, doing like patient training and education for self-management, and that directly is the same thing that the AME is supposed to be providing. Whereas PIN and CHI services, they're a little bit different than what can be provided through Medicaid. So that's why you have a little bit of additional overlap. Somebody's asking if the recording will be shared. That I don't know because I'm not the one actually facilitating the training. So I'll let the wonderful hosts that have organized this series answer that. We do have a few more slides to go through, so I'm going to kind of whip through these just out of respect for time for everybody. Now, when it comes to Medicaid, as I mentioned, there's some differences between the services that are provided. So there's 3 codes with Medicaid, so you can see right out of the gate these are different: 98960, 98961, and 98962. These codes are basically how many people are receiving education at one time. So with Medicaid, you can actually be doing CHW services as a group, which is kind of cool. So you could be providing education to a whole family and do it all at the same hour and be able to bill for 5 different people for the same hour of service. So that's kind of cool because it can maximize your reimbursement opportunity there. And that is important to know. So keep that in mind. You have to make sure, like with Medicare, they have to have that social determinant of health assessment and Medicare, and then with Medicare, they have to have an identified, social determinant of health that's adversely affecting them, and the ability for them to manage their disease. For CHI services and for PIN, they have to have a, serious, very serious health condition that needs assistance with. Now, that's for Medicare, their policy requirements. For Medicaid, they have to have a chronic health condition or be at risk for developing a chronic health condition, or have a documented barrier affecting their health. So Medicaid is actually more flexible in who qualifies than Medicare is. And you have to always ask yourself, does the provider, does the service being provided meet the policy requirements? So before you try to bill Medicaid for any service provided, ask yourself those questions. Can it be billed with one of those codes? Do they meet the qualifications for a billable service? Do they have a chronic health condition? Are they at risk for a chronic health condition? Or do they have a documented barrier affecting their health? And just double check to make sure it meets policy requirements. So as Amanda mentioned, hey, if I want to provide a Medicaid service to a patient with diabetes for health education, and they're enrolled in an AME, she needs to check to make sure that it's not an AME that does diabetic education. She hit the nail on the head of that. She did a great job identifying that, policy caveat. And if they're in one, well, you can't bill them. So you would get stopped at question 3 before you can bill. So I would recommend you do something like this for your billers when you start your operation, when you start to, put this into action and bill. Make little cards and say, okay, before we bill, ask ourselves these questions. So here are the codes, 98960. Like I mentioned, these are all the same codes for education and training for patient self-management, just for a different number of people. And you can see 98960 is for 1 person, 98961 is for 2 to 4 patients, and 98962 is for 5 to 8 patients. One question we get a lot is, can we bill, multiple codes 98961 if we educate the patient and their family on how to take care of the patient? No. Hard stop, absolutely not. Unfortunately, you can't do that. And that's because the code is for education and training for patient self-management. It's not training for the family to help. It's training for patient self-management. So it has to be for patient. But if you have a family who all have similar health conditions, and say they all have, type 2 diabetes, and you're doing education for everybody in the family at that time, then yeah, you absolutely can bill it. So just keep that in mind. It's for patients specifically. You can have multiple patients within the same family, but you can't train family members in terms of how to take care of their family. So when it comes to those qualifications for billable service, here's the policy caveats. Do they have a chronic health condition like diabetes, asthma, depression, generalized anxiety disorder, heart disease, substance use disorder? Or if they don't have one, are they at risk for it? Maybe they went to the doctor and they got a blood panel and it came back with high triglycerides, high LDL, they have a family history of early heart attack and stroke. Maybe they just had a high fasting blood glucose, or their, HbA1c levels were not good, and they have a family history of type 2 diabetes. We're seeing that show up in kids a lot now. So say you have a kid who went to the doctor and that came back, they're at risk for a chronic health condition. You can start providing them services as long as you get a referral from their provider. or they have to have a documented barrier. So number 3 is actually very similar to Medicare caveats, because Medicare, you have to do that social determinant of health assessment, and it has to be a barrier that can affect their health, basically. Well, the same thing here. So that's where you have overlap right here. And that can be, the things we talked about under the Medicare section. So as we mentioned, you want to make sure that you ask yourself those questions before billing or before even providing the service. Now, one of the things that you can do under patient education, training, and self-management is you can provide health system navigation and resource coordination. That is something you can do under Medicare, but there's just different codes for it. You can also provide health education and training, including services to train or increase the members' awareness of methods and measures that are proven to be effective in avoiding illness and are lessening the effects of the illness. It has to be consistent with established healthcare standards. So you have a lot of leeway here. And there's some overlap with Medicare services too, but different codes again. So you have a lot of leeway here. This could be anything from just encouraging people to get up and move more. Just moving has been, just walking has been literally clinically and scientifically shown to reduce gastric reflux. People who were on medication most of their lives who just started walking 2 miles a day no longer need the medication, their gastric reflux went away. So there's all kinds of health education you can do. You can get very creative with that, as long as it's, within established healthcare standards and, proof behind it. Health promotion and coaching to provide information and training to members that enable them to make positive contribution to their health status. This can look like a lot of things. This can look like, hey, let's get you in a smoking cessation program. Or, hey, you have a tendency for your legs to get really swollen from your congestive heart failure. Let's, reduce your salt and let's, train you on, keeping your feet elevated. So things like that. In terms of billing, you can bill, the caveats have been released on this. So you have up to 4 units per member per day. So you can do a max of 2 hours of service for a patient each day. And you can do a max of 12 hours of service for each Medicaid member per month. So that can be spread out throughout the month, however you want it to. The total units allowed are inclusive of all 3 billable codes. So that includes all 3 codes, like 98960, 98961, and 98962. And that's important to note because somebody might get, group patient self-education, and they might get individual, and that all goes towards that total monthly allotment. If additional hours are needed, you have to follow the access prior request process, and you can do it through the Access Online Provider Portal. And if there's any more questions, nope, they are going to be sharing the resources. So Pathway 1, these are the provider types eligible for reimbursement. Because we're short on time, I'm kind of gloss over these, but we talked about that earlier. That's where you make a contract with another biller, like an actual access provider type that can bill. That's ideal for groups that lack billing staff or expertise in billing or lack the funds to support billing staff. That's also very important if your group lacks funds to support setting up an electronic record-keeping system. This is kind of like a bridge to being able to become sustainable. You can build up, your CHW organization savings account and then be able to bring somebody onto billing staff by, entering into an agreement first and building up your sustainability that way before you register for access. That's an option. Under Pathway 1, these are the provider types you can enter into a contract with. So Access has, released a specific list of the providers that can do contracts with you to do billing for you. So take a look at that list, take a picture if you need to. That is the list of groups, and these also are all valid for Medicare. Medicare just has a slightly more expansive list. And they haven't released a list, by the way, Medicare, but their verbiage makes it a little more expansive. So it's a little bit easier. Pathway 2, this is if you register with Access yourself as a group, and you will be assigned a CH provider type. You do not need a national provider identifier right now. Because this is a new provider type, it has a high risk screening level. That's not, a ding or anything like that for CHW organizations. It just means it's a new organization type, and that, when Access does its negotiations with CMS, they have to classify new provider types often as a high risk level because they're brand new. There's an enrollment fee, and because it's a high risk level, you do have to get a site visit. And ADHS is the one who does the certification of your employees, but not of your organization. So you as an organization could register with Access. You don't have to register with ADHS, but your employees have to register with ADHS and get voluntarily certified if you want to bill for them. So documentation and records, we talked about this a little. For the sake of time, I'm just going to let you know that Access can request additional documentation anytime for claims, and so can Medicare. That is standard. I promise nobody's picking on any programs, but it's standard. They can always request additional documentation. Even Access gets audited. So sometimes if they get audited and they have random claims pulled for exploration, if your claims are pulled, they're going to have to take a look and request additional documentation. So just save everything and save it for the proper length of time. Here are things to keep on file. CHR voluntary certifications, the referral from the referring provider, everything on the member condition and documented barrier. Make sure it's detailed. This is not the time for cliff notes, and your visit notes. CHRs, they renew every 2 years. We've talked with a lot of organizations that have, unfortunately, their CHRs were certified and now they no longer are. It expired. They have to get recertified to bill. Any services provided during that lapse are unbillable. Keep your certification records going back 10 years. So just because they suddenly renew doesn't mean you can throw out the records for the past years. Don't delete it in an Excel spreadsheet and then have regrets. It's going to be a pain to go back and have to rebuild those records if they're requested. So keep everything on file for 10 years because Medicare would request them and Access can also request them. Referral, you want to have the referral because that establishes medical necessity. It shows that it was recommended by an eligible physician or licensed practitioner of the healing arts within their scope of practice. Retain that copy as a referral. A lot of CHW organizations will actually send a referral template to the provider for them to use. So you can do that. Information on member condition or documented barrier. So this is similar to what you do with Medicare. You have to have that social determinant of health assessment for Medicare. For Medicaid, you just have to keep whatever you have on the member's condition, something in the medical record, and that should come from the provider doing the referral. So it'll talk about, the chronic condition or that they're at risk of a chronic condition or a barrier affecting their health. So you have to make sure you have that on file. Make sure to abide by all PHI requirements to secure the electronic records. And we just have a couple more slides. Visit notes. Why? Well, CHRs provide a lot of services. I used to be on various audit committees, both at the hospital, at the MCOs, and at Access, actually. And the biggest thing that would result in recoupment of monies is because people had really poor visit notes, not with CHR programs specifically, but just in general. You have no idea how many notes they would look at. You couldn't read them. They were illegible. So, if you can't read them and you outreach the provider and the provider can't read them, well, it's getting recouped. If the visit notes are just very general and just say, hey, provided health education, but you don't say what health education was provided, it's probably being recouped. You need to have details. It would have to say for, say, smoking cessation. You would have to put, went out to patient's house, provided information on smoking cessation programs, on 4 smoking cessation programs within their area, gave them a handout, also helped them to coordinate a appointment with, a psychologist to discuss why they feel the need to continue smoking while they are on oxygen, to work on different behaviors to try to get them to stop doing that. Advise patients of risk and dangers and the possibility of death from smoking while on an oxygen tank. So you want to make sure you're detailed in these notes is the key. And improved services for Medicaid are that health system navigation, health education and training, and health promotion and coaching to give them information and training to make positive contributions to their health status. One thing we see nationwide actually are the effects of diet and sedentary lifestyle on people's health conditions. Sometimes just by changing diet and getting somebody up and moving, it'll help. So document that. And I think we have, we're almost done, just the takeaways. So takeaway, certification matters. Billing can occur for services provided to Medicaid and Medicare members by only those who are certified through the state. They can employ CHRs who are voluntarily certified, but they can't bill for them if that's the case. They have to have a documented health condition that's, a barrier to their health. There are multiple publications on the Access website to guide you, and same with the Medicare site. So that is it, and we got our resources. Any questions? Thank you for letting me go a couple minutes over. Apologies on that. Okay. At any time, Karina? Yeah, thank you guys for putting these together. It's definitely good to get with the community and discuss. I'll leave this up in case somebody wants to take a picture of these different references.
Thank you so much. That was very informative. Thank you, Allison. We are really grateful for you to be here giving this information to us. It's definitely a very good time to think about this, right? So our CHW workforce and the sustainability for our profession is key. And, even we are learning so much just by sitting, and listening in. So we do really appreciate your time and all the effort as well.
Of course. Thank you guys for having me. You're quite welcome. So yeah, if you guys have questions, toss them out. And here's my email. If you're like me and think of a question at 2 a.m., feel free to shoot me an email, once you have a chance to write it down, and I'm happy to help you.